Good evening, everybody. My name's Andy Thomas. I'm a paramedic by profession, and this evening we're going to talk about Crew Resuscitation, hashtag Microgains to improve outcomes. I'm just going to give a few declarations and a little bit about my background, just so it's nice and clear. I do quite a few different things. So I'm the managing director of Cypher Medical Consultancy Limited. I also chair the paramedic advisory group for the faculty of pre-hospital care, and we are leading up a group of people throughout the country at the moment looking at level A practice for non-doctors. I also chair the regional faculty, and I sit on the faculty board. I chair my local basic scheme here in the North East, and I'm a council member of Trauma Care UK. Most importantly, why I'm speaking to you today is I clinically work on the critical care ambulance response unit within the North East Ambulance Service, and we do a reasonable amount of cardiac arrest management, and it's those things I'm going to reflect on today. I'm big into social media. I do like a bit of social media, so if you would like to follow me on social media, it's Andy Thomas 135 on Twitter, or at CypherMC on Twitter. I've got some auto tweets going out whilst this is going on about the presentation, so feel free to look at them and retweet them. And if you have any questions that you don't get a chance to ask me this evening, feel free to email me at andy.thomas@cyphermedical.com, and I will obviously get back to you. So, what we're going to talk about tonight is Crew Resuscitation. I'm going to take a slightly different slant on it. We are going to look at the Crew Resuscitation, but we're really going to break it down into some of its component parts of resus as well, and look at how that can change outcomes. And I thought a good way of looking at this is looking at our Olympic heroes, our Olympic stars. And in the recent Olympics, obviously they did, as a small country like Great Britain, we did exceptionally well. And when you start looking at some of these individuals and what strives them to achieve well, obviously hard work, determination is all in there, but when we really break it down, it really gets into what they call marginal gains. And some of the things these athletes do are making very small percentage differences in how they perform over a period of time. And when you add lots of little changes in, for example, a cyclist would shave his legs, just to give them that extra fraction of speed, and so on and so forth, these all add up to better results. And they've really made a science of improving sports outcomes. And I think that's something, as well as pit crew with obviously the cars and the pit crew concept with the vehicles and Formula One changing tyres quickly, I think we merge these together if we want to get the best out of our resuscitation attempts. And I truly believe this is how we go about it. However, we are medical people and people talk about marginal gains, but tonight obviously my objective is to talk about micro gains instead. I'm not trying to be overly quirky by changing the word slightly, but I just think microgains reflects more of a scientific angle that we're looking at within healthcare, and more importantly, it reflects the sort of very small differences something can make, but when we add them together in, for example, a resuscitation, which is what we're going to talk about, that make a difference. So, looking at some of the things we do in resuscitation, the latest European Research Council guidelines that we've adopted here within the UK have reiterated rate of 100 to 120, depth 5 to 6 centimeters, equal compression, so relaxation, recoil, and we want to keep our off-the-chest times and our pauses under 5 seconds. It recommends that the use of prompt and feedback devices during CPR could help and encourage people to perform better. The importance of early and uninterrupted chest compressions, and a much greater emphasis on pre- and post-shock pause times, or sometimes these are referred to when they're joined together as peri-pause shock times. And these things are really simple things that we can make a difference on. The American Heart Association, just in case this goes out wider afield than the UK, is pretty much the same guidelines, obviously working different metrics, so it's inches. Couple of different things they've got. They want compression fractions as high as possible, at least 60%, and they're looking at they can have 10 seconds off the chest, but I really think the 5 seconds is much better, and everything else is pretty similar in nature. So let's have a look at the pit crew concept. This is not something I've come up with. I definitely didn't invent this. Much cleverer people than I have done this, and they came up with a concept to develop resuscitation using a team approach where everyone has a place. So if you look on the left-hand side is obviously the Red Bull team coming into a pit stop, and when I first started watching Formula One when I was a kid, which was obviously a few years ago, I remember watching Formula One in the days of Ayrton Senna and people like that, and pit times used to be sort of 16 seconds to change tyres. And if you watch them now, they come in and out, and they're under 4 seconds sometimes. And they obviously saw within Formula One that every second counts, and as the cars become more competitive and closer matched and the driver skill becomes similar, they were looking at whatever gain they can have. And as you can see, everyone has a single thing to do within this pit stop on the left-hand side. And when you look at the image on the right, this is what the pit crew concept is trying to do, to evolve into within resuscitation. Now, when I go through this presentation, I will be pulling that apart a little bit, not in a negative way, but in a, you won't always just have 6 people in a pre-hospital resus. In a hospital resus, those experts or that team may take a minute or 2 to arrive. So it's about adapting that to the environment, and but keeping them the same principles to what we're going to do. And I'll go into more detail on that shortly. So what is it? Pit crew resuscitation is simply a systematic team approach built on training to improve outcomes. And that is the simplest way I can put it. It's a team effort working in a synergy to get a better outcome for the patient. So how do we manage this in a real world? And the key point I want to just show in this slide is we need to adapt it to your team, your kit, and your environment. So if somebody is in a toilet and is taken a heroin overdose, for example, I went to 2 resuscitations yesterday from heroin overdoses. One of them was in a decent bit of space, the other one was trapped behind a toilet door. That really changes how you can apply these principles. And for example, that case with the toilet, there was no attempt to resuscitate the patient. It was find a way of getting the door open, move the patient from the toilet into a completely different room, and then create a more open environment so we can adapt those principles. That sometimes is not always possible. What you see on the left-hand side here is a demonstration I recently ran with the Northeast Simulation Conference later last year, and there's a mixture of NIAS and Basics Ambulance Northeast personnel doing a demonstration. And this, what you're seeing here, is the end of a resus, which is a post-ROSC RSI about to take place. And again, you can see there that's not 6 people doing it, that's 4, because that's all that was available at the time. And they would adapt this approach to suit their kit and equipment. On the right-hand side is some of the kit and equipment we use in our area. So we use the Zoll resuscitation system, so including things like the X series, the Autopulse, the rescue pod, and we adapt that to suit our environments. And come on, in your environment, you may be using different devices. They all have merits and pluses, and you need to adapt that to suit your environment. It briefly mentions in the guidelines about using some feedback devices, and this is one thing I'm going to touch on now. I won't labour the point because I want to give a general overview. But as you can see on the picture on the left-hand side, that's the monitor we're using currently here in our region, and we get live CPR feedback. If I just use my arrow there, you'll see the CPR getting performed here. This device actually filters out your CPR so you can see the underlying rhythm, so you know the patient's in VF, which is another way of saving time when you can do pre-charges and things like that. And then although these are American depths here, I do apologise for that, you get your actual chest compressions coming down here, and you get your depth, your rate, your release, and then your predicted perfusion indicator, which allows you to really home in your resuscitation. And again, within the last few days, I've done multiple resuscitations. I had some firemen on one job, and it took me about 10-15 seconds of live feedback whilst they were doing chest compressions to teach them to A, do this correctly, and B, hit the mark every compression. So that's going to make a real difference. Mechanical CPR devices, I'm just going to briefly touch on because there's one in the picture. If you look at the studies, they pretty much say there's no real difference between mechanical CPR and good quality manual CPR. And I can honestly say I don't disagree with that. I think where we compare this in some standard practices, all those studies, when you start looking at people receive significant extra CPR training. And as you and I know, sometimes we're very busy within our NHS practice, for example, and we don't get as much time to train as we'd like. On the unit I work on, we have to do monthly training on these things. I know other ambulance services and Edinburgh's 3RU, I know the RAF cars in Yorkshire, maybe the advanced paramedics over in the northwest. There's a lot more specialised response going on, and that's definitely a way to take this forward. But each thing can make a marginal gain. For example, if you have a young 24-year-old who, for whatever reason, caused a cardiac arrest and you decide to move to hospital, it's going to be much easier to move them with ongoing chest compressions using a mechanical device than it is to try and maintain manual. And this is where they really stand up on their own, I think. In normal situations, if you can get good quality CPR, then it shouldn't make a difference. But as you can see there, it can do. So what are the key priorities around resuscitation? And I'm blending this in with the Crew subjects. Well, high quality chest compressions has been around and is not something new, but if you look at some of the research behind that, we still struggle to achieve guideline CPR. And when I say that, make sure each compression reaches 5 to 6 centimeters, the correct rate and the correct release, which is vitally important. And equally in some training we've done and some internal stuff we've seen before, you can see without feedback this can really be quite varied in range, with depths often only as deep as 2 to 3 centimeters in trained personnel, with rates of well over, often in excess of 140 to 160. So it's not really what we're aiming for. We want to limit our interruptions, and that's a real point I really work hard on within my resuscitations, is absolutely reducing that time off the chest. Defibrillation, making sure we're doing it at the right intervals. And that can be tricky in a resus sometimes. Is it 2 minutes up? Have we done 5 cycles? And again, this is where technology helps. Within our monitors, we've built it in, and it times us down every 2 minutes on the CPR feedback. So you know exactly when your 2 minutes is up for rhythm checks. And that's enhanced by having see-through CPR, so you know what rhythm the patient's in without having to stop, and you can do pre-charges. And controlled ventilations. We will come on to that specifically shortly, but ventilations can be a bit hit and miss. What we must also do is build in leadership. We must have a leader, we must have somebody in charge of the resus, and as a team we must have some followership. I think in paramedic and pre-hospital practice and generally we have sometimes maybe developed a culture where we don't really anybody want to be a leader, we'll just all get on with it and try our best, and results are often still good quality, but I think having a defined leadership is important. And for everyone to follow that leader. Equally, the leader also can listen and take guidance from the team in these situations. And what our aim is synergy of the team effort. So let's use the Olympic rings to improve. Obviously, the Olympic ring stands for the continents of the world, and so I've twitched that a bit and looked at how can that help us improve our CPR. So what do the Olympic rings represent? Well, first we're going to go for CPR, second defibrillation, third ventilation, 4 leadership and followership, and 5 teamwork. If we combine these together, we'll have that utopian approach to resuscitation, that absolutely ideal environment in which we're going to maximize every effort we take towards that resuscitation, making small micro gains in each area to improve outcome. And I've brought a slide up just to say we need Olympians and not movie stars. Resuscitation is about hard graft, it's physically demanding, it takes a bit of a mental strain to get it right and continue the resus, and it takes a lot of thought process to achieve the right aims. We're not pretending to do it like they do in the movies when they're pretending to be heroes or superheroes and other things like that. I think we need to be more like the guys on the left with graft, practice, hard work, rather than the guys on the right just delivering what looks excellent on the screen, but absolutely, if you look at the substance underneath, they're not really the people that they perceive to be, and that's how we must adapt our resuscitation attempts. So let's go through it step by step. So the first one is CPR, and I'm going to show you a quick video, and I'd like to thank Dave Halliwell for loaning me this video to show to you. This is from Smack Dublin, and it's just a little clip about CPR. The volume control on this one is very loud, and I show another video it's very quiet, so I'm just going to adjust my volume here just so I don't blast anybody's ears off before I move on to the next slide, and just watch the next clip. So I think you'll all agree, I'll just move on to the next slide whilst we're waiting, is that the CPR in that slide, in the video, thanks to Dave Halliwell, we saw, is movie star CPR. However, this is CPR that we sometimes see out there on the street, equally out there by professionals, and it's because we get caught in the moment, our bandwidth reduces, and we make the effort, and the things we tend to see is shallow chest compressions, a bit of a lean on the chest, and a very fast rate. And I think that video reflects it quite nicely. Equally, what I like to call movie star CPR. When we're transferring a patient from an ambulance into a resus department or ongoing CPR for whatever reason, rolling along the corridor with this patient in cardiac arrest with one hand, pushing up and down on the chest is really not that effective. And it looks the part, but it's probably not doing anything. And this is when we're going to look at a little bit of the science now. I'm going to show you some papers. I'm going to quickly talk about them, but I'm not going to linger on them because it's more about the approach, and it's just about giving you a taster. There's lots more evidence and research out there. So what does ROSC require to gain ROSC? Well, this study, which is quite an old study from 1990, but this is how long this information's been out there, was looking at that to gain a ROSC, the coronary perfusion pressure needs to be greater than 15 in order to achieve that. When it measured the comparison of what the manual CPR was achieving generally at the time, this was at 12, which was below the recommended standard, and therefore it was all about how can we improve the CPR. As you can see from the graph there, if it's less than 15, there's nobody surviving. 15 to 25, we're getting 46% improvement, and 75% above 25. So these are interesting things to look at, but basically the take-home message here is that obviously we need to create more pressure. So how are we going to do that? So depth of chest compressions. This is a meta-analysis study, so the very strong evidence. So if you think of RCTs and then you put all RCTs together and throw them into the tumble dryer, get some clever statisticians around it and add them up, and then they come up with a chart like this. If it's to the right-hand side of the line, it's pretty good. If it's to the left-hand side of the line, it's not so good. And as you can see here, we're coming to the right-hand side of the line. And basically what this meta-analysis of these RCTs have shown is that survival from cardiac arrest significantly improves the deeper the chest compressions are, with a p-value of 0.001. For those who are not massively into research or into reading these kind of things, that's pretty good. So this means the evidence is strong evidence that suggests the correlation between chest compressions and people surviving is a real one, and it should be listened to. The next study, again, stressed on depth, and this looked at for every 5 mil increase in chest compressions, there was a significantly increase in odds of survival. Now, once you start getting into odds-risk ratios and looking at papers, it can be confusion, but where, for example, if the odds-risk ratio was 2, then you're doubling your chances of survival. And each incremental increased survival outcome on the odds-risk ratio. So that is, again, another thing that's stressing the emphasis on depth. The mean depth was significantly deeper in survivors, which was between 5.5, so 53.6 mils, and the confidence interval for that was between 5 and 5.5. So again, when we're looking at 5 to 6 centimeters of depth, that's where that figure's coming from, these kind of things. Depth of compressions demonstrate survival associated on this study with between 4.5 and 6 centimeters. And a study showed that depth over 6 centimeters often resulted in injury. Now, it didn't necessarily say that resulted in worse outcomes, but obviously we want to try and avoid injuring the patients. I agree, in a resus, you're going to crack a few ribs. It is an aggressive sport, if we want to look at it from a sporting perspective. But actually, that's why we want to aim at that 5 to 6 centimeters. Sometimes if you creep over the depth mark, then okay, you're still going to get the effect, but obviously we just don't want to be too deep. Rate. I think this is the most obvious. I think rate is the thing we can train for the most, but it's often the thing that goes the worst wrong when people are practicing it. So what I mean by training for it, if you do monthly assessments on CPR, you will get to a stage where you are hitting out 110 per minute right in the middle of the box consistently. And when I do CPR assessments using blinded QCPRs or benchmarking and other things like that, using some of the other technological devices out there, one thing I'm always consistent at is a rate of 110. Without feedback, can I hit the depth accurately? And do I get the recoil? Not always. And therefore I rely on those appropriate things, but rate is definitely chaseable. What this says is the faster you go, you compromise depth, and as you can see from the curve, the faster you go, the shallower the chest compression gets. We've already stressed the importance of depth, so this is just reiterating that depth to get that squeeze on the heart effectively, because remember, we are trying to, the heart is protected by that chest wall, we're trying to infiltrate that to get that squeeze going and allow blood to be circulated around the body. So rate is important, but is trainable. Again, this is just another one to say that compression rates increased survival to discharge were correlated in the region of between 100 and 120 in this study by this team here. So again, you can see from the data there, it's a lovely bell-shaped curve, which means that's nice parametric data, and it really gives you an indication in that middle zone of where the best CPR is. So I think we can all safely say we have a good quality CPR is needed, and there's things out there that will help us, CPR feedback, training. Not everyone can be trained, so I do think CPR feedback is absolutely the future on this one. So defibrillation and perishock pause times. This impacts, the longer these are, the worse outcome in simple terms. I do some other bits and bobs commercially through my company, assessing things and looking at people's performance in situ resuscitation and things like that. And when you actually video record a simulated resuscitation environment, sometimes people are actually amazed at how long their pause times can be. And you know, you can get these things in excess of 30 seconds sometimes without anybody even realizing this has happened. So the more we reduce this out, the better the outcome. So let's reduce those shock times down. And again, this is where within my own practice I'm very lucky to have a device that has that see-through CPR, so it filters out your CPR and you know what the rhythm's coming, so I can pre-charge the device. And we look, when we have recently assessed some of our data, we are getting our peri-pause shock time, so pre and post shock pause time, so time off the chest in between shock, to sometimes sub 2 seconds. And that's when I think that's when we've got to be like, safety's important. We don't reduce safety, but we know what's coming. You get the team ready, the person's hands come off the chest, the shock's delivered, they're straight back on there, and which is very valuable. The impact on survival, looking at this data now, this was a lot of data collected, and in this review, the survival discharge was significantly improved when pre-shock pause time was under 10 seconds and peri-shock pause time was under 20 seconds. So this is saying people had a better outcome when we reduced shocks down in total, the time in between, 30 seconds. That's outrageously too high. There can be much better than that, but still that's shown a significant improvement. And it goes to show that sometimes these times are much more significant than that without people realising, especially when you're checking for a pulse, which is difficult in an arrest situation, and you think, have I got one, have I not got one? You get somebody to check the carotid, the femoral, and before you know it, the seconds have passed. The post-shock's important as well, and I'm not going to really go into this study too much in depth, but they were looking at when people, effectively what we want to avoid, and this is the reason I'm bringing this study up, is when we shock a patient, we all know it's in the guidelines, but people still want to look at the monitor. People want to see what the rhythm is and should we stop now. Now, what we're basically saying, even after a successful shock, it's going to take a period of time for that rhythm to change, for example, and often you see a period of asystole post-shock. So if it was VF, you shock, you might see a dip in asystole, and before a rhythm or organised activity returns, you might be a period of time in that. So it's basically saying, get on the chest, stay on the chest, and assess it 2 minutes later. The heart is not in an optimal position to recover, even if you've been successful in converting the rhythm, and it needs a bit more support to be able to work for itself. We want to avoid this. So remember, I mean, we'll take the pad positioning out of the equation just for a second, and say these were positioned correctly. Check your manufacturer's guidelines for your pads, how many shocks you can put through them. Say you're in refractory VF, you've got a prolonged arrest, and just make sure you're using them within the number of shocks. Now each one differs, so that's something to look at. What we don't want to do is start frying the heart. Equally, after prolonged use, the gel and all these things that improve conduction of the materials and allow that electricity to pass through the chest wall will reduce in effectiveness. So it's just something to be bearing in mind. If we're on a shock 20, our pads are probably not going to be that effective at that time. Now, some of you will be saying, we're on a shock 20, they're dead, but actually there is case series where people after prolonged arrest can survive, and especially in young, fitter populations, so we don't want to rule these people out. Ventilation. Ventilation is another interesting one, where we see variation in the ability to ventilate. So I'm going to show you a quick clip. The music on this one's a little quieter, so I'm just going to turn mine up, just so hopefully it'll come across to you a little bit better. And I'll just press play, and then I'll talk a little bit about ventilation. So if you just watch how quickly he's bagging, this is a training scenario. and we'll ignore the ineffective CPR as well. So he's going to take over. Oh, beautiful. That is not how we use a ventilate. That's not how we ventilate patients. It's definitely one for the cameras. And how much tidal volume do we know he's squeezing in there? Probably far too much. So yeah, too much volume, and too much volume cannot be the ideal solution for the patient. The person who did that did it actually deliberately for the video, and it was just to prove a point. But I remember in my early days in the military, when many years ago, and that's certainly how I used to get taught to do resus. Yeah, if you're on your own, put it under your knee, squeeze the bag in, and obviously at the time I didn't know any better, so I would follow that religiously. But obviously that's the whole point of moving on. We do get educated. So ventilation rates. We all bag too fast. Let's not beat around the bush. I've never come across anyone bagging too slowly, but it's a comfort zone. If you've been given the grand responsibility of ventilation, people tend to hyperventilate patients. Hyperventilation is not ideal in a cardiac arrest situation. You're just going to blow off too much CO2 potentially, and the more you ventilate, the less we're going to be able to get in, the more pressure in the chest wall, and the less blood flow effectiveness we're going to get around the body, which is not what we want. We want to maximise that as much as possible, and therefore, as I say, we don't want to overventilate. And it goes across the board. Pre-hospital the worst, in-hospital fine. Ignore that. That's just an old slide from this study, but it doesn't matter. The guidelines are the same. It's definitely too quick. So let's move on. Sorry, I just messed my screen up there. So impact on ventilation in some swine models and looking at CPP. So the study demonstrated that ventilation rates increase thoracic pressure, impending flow, and causing a CCP to fall. So that the coronary perfusion pressure we're after. More importantly, hyperventilation results in increased mortality. Now, so we want to ventilate at the correct rate during CPR. I can't touch on everything in tonight's talk, but I'm just going to briefly mention capnography in this slot now. I use capnography in all resuscitators, as probably everyone who's listening tonight does. It doesn't matter what airway you've got in, as long as you get a C, you will get some feedback. But say you've either got an iGel or an LMA or a tube down, then I would ventilate to end tidal CO2 even in a rest situation. You can often get absolutely normal end tidal CO2 in the cardiac arrest situation when we are doing effective CPR, good airway management, and doing the basics very, very well. I mentioned, I've obviously referred to a few of the arrests I've done this week, but I went to a hypoxic arrest from a choking 3 days ago to an elderly lady who choked on beetroot. And when we were resuscitating her, she had an end tidal CO2, she had a PA arrest, quite normal, and then I suddenly got a shoot up on the monitor to about 9. We checked for a pulse, and that was our indication. She was obviously, the end tidal was higher than I'd like, and we obviously ventilated that down to normal ranges of around about 4 to 5.5, but it was just an indication that these things can suddenly happen. Hyperventilation is not what we want to avoid, but if sometimes post-ROSC, and especially when good CPR is, I sometimes see end tidal CO2 around about 10, 12, and what I often do is just for 30 seconds, just hyperventilate ever so slightly, get that back down in normal ranges, and then that prevents the patient becoming acidotic in the post-ROSC situation. When we're talking about microgains again, this is just airway pressures with and without something called a rescue pod, so an impedance device. I don't profess to be an expert on this device in any way, shape or form. We've played around with them up here and did some sort of usability trials and seen what, not in a wide-scale study or anything like that. And I've seen some stuff on how they work in cadaver labs, and they've got a real potential, I think, in resuscitation. To improve outcomes. Again, it's another microgain in the toolbox, and if you look at airway pressures in normal resuscitation, the compression rate can be systolic low. If we increase that systolic rate and increase the diastolic rate, we can get better blood flow, positive pressure that reduces cardiac output. If we increase the space basically in between these chest compressions, so for example, CPR shows around about it provides about 25 to 40% of normal blood flow. Other things can limit that, and the problem is the airway is always open, so it's always drawing in air. These devices stop it drawing in air and reduces the pressures that it needs to, which increases coronary blood flow and potentially then increases better outcomes for CPR. It only works if we're doing good CPR, so if you put one on and we're doing rubbish CPR, you may as well have left it in the bag. So this is when you start talking about a system of resuscitation. There's lots of things that make a difference. There's more technology development now, but it's fundamentally the basics that make a difference. Good quality chest compressions. Without that, things like this won't even make any difference whatsoever. So another way if you're ventilating a patient and you're in a high pressured environment, it's easy me standing here sat on my chair at home saying you should do this and you should do that. But we all know our pressure comes up in a cardiac arrest situation. For road staff or people not exposed to it on a regular basis, it could be the one they've done in 3-4 months, and that can apply pressure. So when you're ventilating a patient, I've got a simple story, and it's date night. Imagine, and I'm going to tell it from my perspective, and please bear with me on this one, but imagine you've gone out for a date, and I've taken a lady out for a date, and it's gone well, so we've gone back for coffee, and things start heating up a little bit after coffee. So we get down to it, and get down to, you know, a little bit of things going on, and we decide to progress to clothes removal. And there really is a point to this, so do bear with me. It's hard to tell over the internet. It's definitely a better story in person. So what I wouldn't do with a lady if I was trying to woo her for the first time is I wouldn't just go take a bra off and start grabbing her breasts, because I suspect I'd get a slap in the face and thrown out the door, because I don't think that would be pleasurable for anybody. And that's what you've got to treat a BVM like. So imagine that if you wanted to keep somebody in suspense, or in my case I'm a man, so a female counterpart, I might gently stroke the breast and just aim over a nice gentle period, just to have an end with a little nipple tweak at the end of it. And if you kind of visualize that with your hand, what you're going to do is just gently squeeze that BVM, not the breast, and tweak it at the end of it. Have a pause to allow the moment to savor in the air for 4-5 seconds, and repeat the process. If you think of that when you're doing your next time you're doing ventilation, I guarantee I think you'll ventilate better than maybe previously. Equally, if you want to put a complaint into me this evening, I've left my email at the front, so you can do that, obviously. Leadership and followership I've already touched upon, but it's very important to have a leader, and it's equally important for the team to have some followership around what's going on there. We must follow the leader, but equally we must say if something's not right, and equally the leader may ask for advice from the team. The team may be multi-professional and may vary in experience. I've done a resuscitation on my own just with a bystander and had very good effects, because I've taught the bystander how to do CPR with CPR feedback as we've gone on, and we've worked as a team and it went well. In fact, bystanders take direction probably better than most healthcare professionals when it comes to resuscitation. However, as professionals, we must all get used to helping each other out and actually taking a bit of advice and positive support at the scene of these things. Teamwork is key, guys. If we go there as individuals, it all goes wrong. If we work as a team, we'll improve. And in simple terms, teamwork makes the dream work. So definitely got to have a bit of teamwork going on there. So how are we going to improve things simply? We've covered a lot of the things there, and I'm just going to show you a next slide to keep it nice and simply in one slide. So basics, basics, and basics. If we do the basics well, we'll do very well. Chest compressions, as you can see from the imagery, of 5 to 6 centimeters, rate 100 and 120. We must get that recoil, call for help, apply the pads, consider the chain of survival, reduce interruptions, work hard individually if you're doing chest compressions and as a team. You should ache after you've done a cardiac arrest, especially if you're not used to doing chest compressions properly and you start doing them properly, you do feel a difference. Use technology if available, CPR feedback, other devices, whatever will improve the outcome. We often use IO needles, for example. Now, I certainly use an IO needle generally as a first port of call. I think getting an IO in reduces everyone's stress of bandwidth, and then follow that up with secondary IV access. Work together as a team and have a culture of correction. If you see somebody doing poor CPR, correct it. Don't think, I don't want to say anything. And when I work in some environments, I've taught this to groups of people, I've said to emergency care assistants before, if you come to a resuscitation with me, just because I'm on the critical care card does not mean you can't say, Andy, your CPR is rubbish there, you're improving. There's the machine's telling me you're not deep enough, and that might be an indication somebody's fatigued or somebody's just not doing it right, and work together as a team and support the team. Don't just say you're doing rubbish CPR, just give a bit of coaching. So how does this reflect back to the pit crew approach? Now the pit crew approach has all these positions, and I've gone into a bit more detail of what the original concept of this came out as. So position 1, team leader, makes all the decisions, communicates with the team. Position 2, the airway, secures the airway, confirms placements, concentrates on appropriate ventilations. Position 3 could be down there looking at the monitor and getting IV access. Position 4 on the left hand side of the patient, quick pulse checks, resume chest compressions, rotate that round. Position 5 on the patient's right, apply the defib pads, rotate ventilations and chest compressions if needed. And the person in position 6 would make sure the O2 is getting replaced, look after the BVM needed, get a kit done, look for history. Now, this never happens. You don't just arrive at 6 people all experienced in doing resuscitation regularly. So it's a bit of a myth. That I'm not saying you can't achieve this, but it's a bit of a myth, and we're going to try and break it down. Another way of looking at it is, it's not always that simple. Houston, we have a problem. I'm sure Tom Hanks obviously didn't really go in space. He was just mimicking somebody else who did it. When he had a problem there, they worked through these problems systematically, and they got these people home. And the cat probably didn't envisage he'd end up like that. But it looks funny for the program, so I thought that would break it up a little bit. What we must remain is flexible. If you Google these 2 people, these are the most flexible people in the world, male and female, apparently. I don't know how you go about getting that title, but yeah, these are the people that are the most flexible people in the world. And I don't mean you need to bend your body around, but you need to have that mental model of flexibility to your team. So I'm going to show you a patient next who's collapsed and is needing resuscitation, and I'm going to show you some of the team positions you can adopt. Obviously not a real patient, just using a gingerbread man here, and I've simplified it a little bit here. So say we've got 3 people. So within paramedic practice on our ambulances and cars these days, we're training a lot of student paramedics out there. There's a lot of student nurses come out. And there tends to be always multiple people in some way, shape or form. So if you're on an ambulance, often there's 3 people now because there's an observer or some other person. If you're in a car, there might often be 2 people. Some of you will be saying, not my air, I'm always on my own, but this is the concept. If you arrive on your own, if it was me, I would apply the defibrillation pads. I would probably go to the head end, put an eye gel in, and I would start until the cavalry arrived. If I was position number 1, and then the cavalry arrived, and I got another person or another 2 people in there, I'd get this person on the chest, I'd manage the airway, and I'd get this person to look at the X series, sort the defibrillations out, and maybe prepping some kit in between cycles to assist us. And that is a pit crew approach. People have a role. We can swap 2 and 3 round when they get tired, or if we've got a reasonably secure airway through an eye gel, for example, we can move the person between CPR and ventilation without either of these people moving. So if I was ventilating, 2 minutes, deliver a shock off the device, this guy now can just grab the BVM, which will just be over here, squeeze it in between my 30 chest compressions, or asynchronous if we've got a good seal, and I can just lean over the chest. Some evidence in the past has said leaning over the chest is not ideal, you don't do as good quality CPR. But what I've found when we've looked at this is using CPR feedback from the devices we use, we're getting good quality feedback so we can see what we're doing. And then every 2-minute cycle, I rotate this person, just swaps their, nobody moves, and that pit cruise concept, but we're covering 2 jobs. And that's adapting it to suit your team. So adaptation is key. And again, these small things are micro gains. So if I was to physically swap these 2 people around here, there's going to be extra seconds off the chest. There's no way you can do it. Where literally leaning forward and not moving reduces that by a second, maybe it's a half a second, but it all counts in the micro gains to resuscitation. Additional resources arrive, so in our area we send 2 vehicles to every resuscitation, and sometimes a 3rd vehicle. So for example, if we attend, often there might be 2 vehicles on scene, and we're the 3rd vehicle, so that's when we get to the 5 people, the 6 people out there, and you can start adapting the situation to suit yourself. I'm just going to flip the next slide up, just to give you a concept here. So what are the skill grades of the people that attend? So in this situation we've got 1 paramedic. The paramedic arrived, maybe he's on the first ambulance with his ECA crewmate. We might have had an urgent crew or a St. John crew backing it up, and that crew might have had a student nurse on board. And how do we adapt that? So the airway management might require some extra intervention. So in this situation, if it was maybe me, I might place myself at the airway and just only focus on airway management, but whilst managing the rest of the scene, use the nurse maybe to get some information, pass a bit of kit around. The ECAs could be working together on doing good quality CPR from either side, but the importance is that anybody who's going to do CPR can see the monitor, and so we might say, actually, come in at this angle, do it over the top. It's about adapting to your coming. We've got the person assisting in the airway management and checking the bottles should it be right. So we've developed a pit crew approach, but we've looked at potentially the skill mix. And the skill mix and how we deploy that. If that was 3 paramedics, would it change it? Probably not that much, apart from, yes, I would probably have the other person stood off down here, going through check sheets and other things like that. What can help? Well, I know many people here tonight will have done CRMM talks, but can you imagine if you got on a plane, you just were about to take off, and the captain comes, "Hi, it's the captain speaking. I've been off sick for a couple of months, so if you bear with me a few seconds, it's just going to take me a few extra minutes trying to remember what buttons I need to press first, and then I'll get us in the air, and I'll give you an update once we're at cruising altitude." I think we'd all pretty much want to get off the aeroplane at that point. Everything they do is on check sheets before they take off, as they fly in. If there's an emergency, they just follow drills. And I have to say, watching the name of the film's Sully, Sully, for the plane that crashed in the Hudson a few years ago. And you know how they dealt with that emergency on the film, which obviously is a film, but I'm sure it was pretty close to life because the guy managed to land it on water. Was that professional approach, using check sheets, going through things, and what he did is he used a check sheet, but on one of the key points of that film is he switched to auxiliary point power ahead of the check sheet because of his years and years of experience. So absolutely, check sheets are brilliant, but don't forget we've got clinicians there with brains, and that helps also. And if there's a reason to step outside of a check sheet or a reason to do something out of order, and you've clinically justified that, is perfectly appropriate as well. This is just a similar check sheet we use here. I'm not going to dwell on this, for example, but these are something that we pull out at every cardiac arrest. We have the cardiac arrest checklist, we do a post-ROS check sheet, and these are just guiding us. And we have other check sheets for different things, but this is just giving us an idea of some of the stuff that we have available to us. And if I'm the team leader at an arrest, I will stand back and I will just talk through this. For the reversible causes, I'll say hypovolemia. Does anybody think there's any chance of hypovolemia in this situation? If so, what do we need to do about it? No? Okay, move on. Hypoxia. Yes, we thought the patient choked, they were hypoxic. We've now got a good airway, we reverse that cause, move on. And that's how we go about our business and doing that. There's many other check sheets available and getting used around the country. This is not an absolute one by any stretch of the imagination. So, what's our end game? Well, we want more survivors. Is there a silver bullet? Is there one magic thing that is going to make a difference to cardiac arrest survivors, to pit crew resuscitation? The answer, in simple terms, is no. So I've used the example of 300 here from the Spartans, and again, I hope these are just film images, but you know, the Spartans 300 fought off thousands, because when they found this place, they got the enemy to come into that place, and they were all worked together as one, very strong team approach with a single leadership, and they pushed through hard and defended there. And that's what you have to think about it. Each small bit of training that they've got, unfortunately the Spartans used to get rid of their less than physically able offspring, which is not what we would do in society today. However, you know, they've trained hard and together, and that's what we've got to look at resuscitation. The other end game, in simple terms, these are my 3 kids. So if I happen to have a cardiac arrest tomorrow, I would like to think people would think of all the different microgains they can do, a little bit better CPR, a little bit better airway management, reducing the shock times down, and hopefully make sure that I get to see these guys again, because we do a lot of resuscitators that aren't successful, but you know, when we do a successful one, and you either get a thank you letter or the family, you see family relief that their loved one survived, I think that's well worth it. And remember, we don't rise to our expectations, we fall to the level of our training. When the pressure's on and your bandwidth begins to narrow, you'll just go back to what you've trained on. And if you haven't done a lot of resus training in the last 12 months or 2 years, you haven't been to a lot of resuses, you're not going to be brilliant and perfect. You shouldn't beat yourself up about that. You can only work with the tools you've got, but just accept that limitation. If you do get opportunities to do any training or go to conferences or anything like that, then take those opportunities. And I will be giving you a quick thing at the end of here where I've still left open some free places to trauma care. And for 15 minutes at the end of the presentation, I'll give you the link that Andy will link in, and I'll send it out on the message board in a second. And if you register, you're in with a chance of winning some free tickets there. So again, opportunities to train and learn more. So in summary, because I'm sure you're pretty bored of me talking now, is good quality CPR, defibrillation, reducing peri-pause shock times. That's a mouthful, and I've not been able to say it throughout the whole presentation. good quality ventilation, remember, date night, and you won't go too far wrong. Leadership and fellowship, and we're all sort of part of the same team. It doesn't matter whether you're a consultant in emergency medicine, or you're a healthcare assistant, an ECA, or the community first responder. We all have a voice. We all work together for the input and the better outcomes of the patients. So Andy will come back on now, and I'm going to close the presentation down so I can see any questions that are coming through as well, and I'll wait for Andy to read them out. But I'll take some questions now, and then what I'll do is I'll send the link out as well whilst those questions are coming in.
Oh, perfect.
Andy, are you there?
Yeah, I am. Thanks very much, Andy. We can still see your screen. Have you got something else to put on the screen for us, Andy?
Hello, Andy?
Hello, have you got something else to put on the screen for us? Oh,
okay, Andy doesn't seem to be coming on the line there. I don't know if he's I'm hoping he hasn't collapsed of any kind of cardiac arrest or anything like that. And if so, if somebody wants to do some good quality CPR, then they need to jump on. If you want to ask any questions, if you just type them into the question box, I'll be able to see them come through. And we'll just see what's going on. I'll just try and...
No.
Okay, so we've got some questions. I think Sarah's going to read out the questions, and hopefully we'll get Andy to answer if he can still hear us.
Okay. So the first question's from James, and what he's asked Andy is, who is the best person to be the boss? Sometimes having a team leader or an ambulance manager can be negative to a scene, perhaps.
James, yeah, good question, and we've all been there. We've all been there when somebody turns up and they've got more pips on the shoulder than you, and they come wading in there and it all goes wrong when something was going well. Training's key. I don't think there's any one person right for the job. I think it needs to be somebody with good clinical ability. The more better your people skills are, it helps. And I suppose I'll put it into context. Often I back up teams in a situation where I have to go into that resuscitation, and I alter my approach to that. Sometimes I blend in clinically because there's great leadership going on, and there's no point me wading in there saying I'm in charge now, because let's be honest, everyone would just get upset and I'd look like a fool. But equally, sometimes things you might get there, and maybe as you say, a St John's crew or an ECA crew who are under significant pressure, and they may need that strong leadership to regain control. So I don't think it necessarily needs to be a manager. What I do think is those who are exposed to cardiac arrests more can generally know what steps to take, maybe when they're using check sheets. So it depends on your trust in your area or whatever clinical environment you work in. So if you've got somebody who's exposed to cardiac arrest more because they work on a specialist response, so as I've said in the thing, 3RU in Edinburgh, one of them would obviously take the lead. We generally take the lead. RAT cars in Yorkshire, maybe it's APs in North West and London. It's whoever's really got the best ability to lead that. So yeah, somebody clinically competent, sound, that can respect and command the respect of the team, really.
Okay, that's great. We have another question from Jill. Knowing that in hospital the resources are different, usually more staff, do you think this approach works in hospital cardiac arrests?
That's a great question, and what I would say is not right. What I would say on that one is I've been waiting in hospitals before when an arrest happens on a ward, and first of all, where does everyone come from? I'd love to know. I think what you suffer from in hospital is too many people, and yes, if you get strong leadership in the bed and you organise maybe the doctors in order, because obviously a lot of these things, there's medical students, there's a student nurse, there's mid-grades, there's a consultant, and everyone wants to get in there on the action. Actually, somebody needs to take control of that and organise somebody on airway. So if they're an anaesthetist there, put them on the airway. They have an assistant. Have a couple of good staff who can do good quality CPR, alternative sides. Have somebody stood off leading, and I would say the most senior consultant should stand off and lead and not getting involved in any treatments, because we want them to think about what's happened to this patient, look at the records and how you could reverse that. So I do think it's adaptable, and I did some training around CPR feedback in hospitals over the last few months, and we've talked about pit crew concepts, and equally I've shown a few of them check sheets as well, and that was quite an alien concept in a hospital. What do you mean we pull out a check sheet, we know what we're doing? But then when I went through it and said practice a few scenarios with it, it's had good benefit. So I think the key is if lots of people turn up, say 20, you can't fit 20 people in between them curtains and an arrest. You need 6 people. Everyone else should be standing behind a line like they would maybe in the emergency department, and consider some check sheets. Maybe your resus department wants to bring in the check process, and I think you'll find your resuses will run a lot smoother.
That's great.
Hopefully that's answered that question.
That's great. Thank you for that. We don't have any more questions currently.
Okay. What I'm going to do quickly then, I'm just copying a link. And I'm just going to put the link into the questions box. So if anyone wants a chance to win a free trauma care ticket, I'll leave this open. What time is it now? I'll leave this open until 9 o'clock. And if you click on the link, you can register. There's 75 places up for grabs. I'm just trying to find my little go-to webinar box to put it into. There we go. So if you look in your questions box now, I'm just going to paste it in there. Sorry, 2 seconds.
Cheers, Andy. Just to mention, if anybody does want to ask Andy a question verbally, if you pop your hand up on the webinar, we will be happy to open up your microphone so you can ask Andy a verbal question.
Andy, could you do me a favour, mate? Could you just post the link, make sure the guys get the link to the thing? For some reason I can't post into questions at the moment, and I don't know why.
Yeah, of course I will, yeah, I can do that.
Cheers, mate. Any other questions?
There doesn't appear to be anybody at the moment. What I'll do is I'll just explain to you what will happen at the end of the webinar for those people who are quite new. You will get your certificate, as I said, emailed to you. But for those people who are members of CPD-Me, the certificate, the link to the recording will drop automatically into your portfolio. So it will go into your CPD dashboard, where you just need to reflect upon your learning experience. That is where your dashboard is. And so as you can see, you've got your diary entries. It will appear within your diary entry section, and you just need to then reflect upon your learning experience. Sarah, do you want to go through what's coming shortly webinar-wise?
Yeah, we've got, we're hopefully going to now start having 6 months ahead of webinars. So we've got the next one in March is taking an asset-based approach with our patients. We've got a talk on the place for simulation in clinical education. You're going to be talking about the clinical skills app and doing a demo on how to use it to improve practice. We've got advanced life support courses in the UK. We're going to be talking around the trauma cell that North West Ambulance Service use, ambulance care pathways in Wales, how to deal with decision fatigue in crisis management, and interactions in groups and how to get the best out of people.
Excellent. So there's a few webinars there for different people. I'm noticing we're not just going for an emergency theme anymore. We had quite a lot of requests for the webinars to be a bit more wide and broadened rather than just pre-hospital. And so we've tried to do our best by varying it out a little bit. I will post that link for you, Andy.
I've managed to get it up there. I think everyone should have been sent it all, and I've just noticed Dorothy from the Red Cross team, there's a few of them been watching the webinar at night, so thank you, Dorothy, and the team there. Yeah, somebody was just asking for some dates for the next CPD webinars, but kindly Sarah's already done that, so great stuff.
I think I can probably pop up the dates on my screen. If you click onto cpdme.com/webinar, you will see that they are all listed in reverse date order. And so tonight's pit stop resource there. And what will happen is once the webinar has taken place, the link where you would register turns into a link to the recording. So for example, if I go to a previous webinar, so we'll go to this one here, which was CPD on human factors design, you'll notice that the link there has gone from the register to the watch the video. And if you click on watch the video, up surprisingly will pop the video, and you can use that again for CPD. One of the questions we get asked quite a lot are, do you get a certificate for old webinars that you have watched retrospectively? Well, we're having a new system built, and hopefully that's going to launch April or May, and you will have multiple choice questions and answers at the back of the webinar. So if you answer those, you will get a certificate automatically. It drops into your portfolio with a copy of that recording. So to find the dates, in short, just go to cpdme.com/webinar, and you can see the date of all these listed webinars. And all you need to do is just click into one. So click into that one there from decision fatigue, and at the very bottom, you'll see there's an option to register now. Okay, so I think that is pretty much us for this evening. Thank you very much indeed, Andy Thomas, for being a fantastic presenter as you normally are.
No worries, Andy. Cheers. Thanks for having me, mate.
And thank you very much indeed to Sarah Harris. Sarah, you'll be hearing more from because she will be managing the webinars from tonight onwards. And so thank you, Sarah, and welcome to the CPD-Me webinar.
Thank you.
Thanks so much, ladies and gentlemen. Again, if you've got the rest of the evening off, go and get yourself a cup of coffee and a biscuit and enjoy. If you're at work, then have a safe shift. And thanks so much for attending. Good night.